My name is Mike McNitt-Gray. I'm from UCLA, and I'd like to welcome you to this session this morning. It's an imaging symposium, patient dose in CT, calculating patient-specific doses in CT. This was part of a several-part series that we did jointly with the education track. The education track session was yesterday morning, and today concludes at least the CT portion of it. I'm going to be doing this in conjunction with Peter Caracappa, who's filling in for George Zhu from RPI. And he'll do the second part, and Ehsan Sameh from Duke, who will do the third part of this. So we're going to do a little joint session here. I'm going to talk first about the limitations of current metrics like CTDIvol and methods in estimating patient dose, and then I'm going to talk a little bit about methods to accurately estimate dose to take into account scanner, exam, and patient factors. Peter is then going to come up. And so we'll have a couple minutes for questions in between that. Then Peter's going to give the second part of this session and talk about the role of computational phantoms. He's going to talk about Monte Carlo simulation and developing patient-specific dose estimates. And then we'll conclude with Ehsan Sameh, who's going to talk about patient-specific organ doses, effective doses, and risk, and a little bit about a word about optimization. So let's start with my part at first. And here's my disclosures of some funding from NIBIB and a research grant from Siemens. And before I get into the technical details, I wanted to plant some seeds in your mind about questions that you should be asking us, or some others that I'm sure you'll have as well. But we specifically picked this topic to be a little bit provocative and to say even things like, should we calculate patient-specific dose? And if we do, how accurately do we need to do this? And does that depend on the exact situation? In other words, do we need to be very accurate in certain cases like fetal dose and other times when we're just tracking patient exposure over time or something like that? How accurate do we need to be? Do we need to calculate dose for each individual patient that walks through our practice? Or do we need to just assign them to a class of patients like a large adult male or a petite adult female or child, things like that? And what would that involve if we were to do it for individual patients versus a class of patients, such as things like doing real-time Monte Carlo, et cetera, et cetera, okay? So hopefully those and other questions that you have in your mind will come up today. So we know what some of the background for and motivation for this is, that CT has now become a very significant component of the medical radiation exposure to the population in the U.S., and I'm sure other places as well. It's now 50% of the medical exposure, 25% of the total annual exposure to our population. Estimated procedures have grown somewhere in the neighborhood of 10% per year for a very long sustained period. Something like 18 million procedures in 1993. About 62 million were estimated in 2006, and some people have estimated that we're probably over 100 million per year right now. So let's talk briefly about dose metrics. A lot of organizations have come out and said we should record CT dose and that it should be tracked, right? The NCI came out and said that they're not going to buy any equipment unless it can report dose. The IAEA has a little dose card or something. ACR has a dose index registry, also advocating tracking dose. And the FDA has also come out with a dose tracking card. So lots of people are saying we should track dose, including our state of California, which said in the state Senate Bill 1237 that it required reporting on CT dose, and we have to comply with this by July 1st of 2012, that we record for each exam that we perform. Inpatient, outpatient, freestanding clinic, academic medical center, doesn't matter, but we have to record the CTDI and dose length product as defined by IEC and recognized by FDA, or, thanks to John Boone, we can record the dose unit as recommended by the AAPM. So we actually get some say in this, and that was meant to give us some leeway to move from CTDI to things like dose equilibrium or something, whatever we're going to do from TG111 and TG200. But let's talk about right now. What's available to be recorded now? CTDIvol and DLP. And I'm not going to go through those definitions. I hope that you know what those are, but I am going to talk about the limitations of them. But what could we do in the future? This is what we have right now, and let's talk about what we would really like to do in the future. And I'm going to submit to you that something either based on or derived from organ dose that could be tracked across scans and across time, and accumulated organ dose over time could be recorded as well. Okay. Oops, did I go too far? No, okay. So let's talk a little bit about CTDIvol and DLP and see what they tell us. It is dosed to one of two phantoms, either the 16 or 32 centimeter. It is not dosed to the patient. Okay, those of you that heard my SAMS course yesterday probably are tired of hearing this. Good. Somebody answered yes to that question yesterday. You saw that. It's because of them that you're hearing this again. The CTDIvol does not tell you whether the scan was done correctly. It doesn't tell you whether the scan was done ALARA, or whatever that means in this context. Okay, at least it cannot tell you that if you just see the number. Okay, you have to have other information, such as the size of the patient, okay, the body region that was examined, and preferably some other information as well. But those at least inform you whether or not the number you got out was reasonable or not. Right? When you see 50 milligray, if all I tell you the scan was 50 milligray, what's going through your mind right now? That's a high number, that's a low number, and probably a little bit of both, where you said, well, that's low for a head, but it's high for a pediatric body. Right? So you need a little context for that to make sense. It can be used as an index to patient dose and organ dose, and I'll show you a little bit about that later. Okay, so Cynthia McCullough wrote a letter to radiology, and it was called CTDI and patient dose. They are not the same thing. And she argued that CTDI does represent a measure of scanner output with limitations that are being addressed by our task groups 111 and 200. It is well defined and it is highly reproducible across scanners. So if I tell you how I measured it and I get a number of CTDIvol, you could do the same thing and come up with a very, very similar measurement. And it's a good indicator of scanner output. It's just not patient dose. Okay? Because it doesn't take into account the patient size. Remember, those phantoms are just one size. So it doesn't take into patient size, shape, composition. It doesn't take into scan length either. DLP helps take into account scan length. And it also is not a very good metric of patient dose when you have scans with no table motion. It actually is an overestimate of the dose. Okay, so a couple of brief examples. Let's say you had two patients, and in your practice, you did not adjust the MAS for the patient size. Okay? Small patient on the left, big patient on the right. They both have 100 MAS, and the CTDIvol recorded was 20 milligray, okay? Because that's the dose to this phantom, not the dose to that patient. It's the dose to this phantom, okay? So the CTDI for these two would be the same. But I submit to you a question, which is the dose to the patient the same? Okay, how about this scenario? So now, in this case, we do adjust our techniques appropriately, take it down to 50 MAS for this patient, and now this says 10 milligray, this says 20, and we say, okay, we did that appropriately, but the patient sees this and says, hey, how come I got twice as much dose as that guy? Okay? Because that's what they're seeing is the scanner output was double, but in fact the absorbed dose probably was not. It was probably close to similar. Depends on the size of the patient. Okay? So in those two scenarios, CTDI was the same in scenario 1, but the smaller patient's dose was actually higher. And in scenario 2, the CTDI was smaller for the smaller patient, but probably the patient dose was probably closer to equal for both of those. So that's why we say CTDI is not patient dose. It doesn't tell you really what you want to know. Okay, so thanks to John Boone and Keith Strauss and a number of other folks, I was fortunate enough to be involved in this. AAPM report, Task Group Report 204, size-specific dose estimates. I actually went through a bunch of work, simulations and measurements to say, how do we take into account patient size? So we came up with, actually we, the royal we, which usually means John, came up with this effective diameter metric. We used other metrics, but he kind of coalesced our data, and so it all lined up very nicely. So here is a metric of patient size, and here's a normalized dose coefficient. This is the number that you would multiply the CTDIvol to adjust and get a size-specific dose estimate, okay? So appreciate that if CTDI was patient dose and size was irrelevant, then this coefficient would be 1, right? It would be 1. There would be no adjustment. But you can see what happens. If you have small patients, you've got to multiply by a number. And peds patients, And by the way, this particular chart is based on the 32 centimeter phantom. And yes, some scanners report CTDI to pediatric abdomens on 32 centimeter phantoms. So we have this table. We also have another table in the report where it's based on 16 centimeter phantoms because some manufacturers report on 16. Okay, someday we'll get that sorted out, but not just yet. So you can see sometimes you have to multiply, especially for little kids, okay, up to 2.5, you have to multiply that number that comes off the scanner. Okay, and for larger patients, you actually have to multiply by a number less than 1. So the CTDIvol is actually an underestimate for those larger patients. So CTDIvol underestimates those for small patients, so you have to multiply by greater than 1, and overestimates those for large patients. Okay. So by itself, CTDI can be misleading. It's not patient dose. And whenever it should be expressed in the context of the phantom size and hopefully some description of patient size. I realize that's difficult to get right at the moment, but we're working on that. Okay. What about tracking and reporting dose? This is really problematic, isn't it? What should we record or report? Well, we're going to be forced to record or report CTDI and DLP in California. But what do we tell the patient? And what do we tell the referring physician? That was a 50 milligray scan. Is that a lot? It depends. Okay. What about calculating effective dose from the total DLP? Some people have advocated that. So I'm not going to answer that question, but I'm going to provide you with some other ways to think about dose that's going to move into the future. I'm not answering the question about what we're going to do tomorrow. That we'll talk about outside. But let's talk a little bit about further down the future. And I'm going to talk briefly about Monte Carlo simulation methods for estimating radiation dose with a particular focus on organ dose. Okay? So don't think about CTDI completely just yet. Don't forget about it, but don't think about that. But let's think about what we really want to know. What's the dose to an individual organ, to an individual patient from a specific scan? From that, we could derive effective dose or a BEER7 risk calculation. So the fundamental building block is an organ dose. But let's talk about Monte Carlo methods, because that's going to be one of the ways that we get this. And the Monte Carlo methods have been used in CT for well over 20 years. NRP report 250 in 1990. The GSF started doing this also around the same time frame. These are the basis for things like impact. The dose calculator are based on Monte Carlo simulations. CT Expo, I believe, is also based on Monte Carlo simulations. So these early reports used detailed models of single detector axial scanners. Again, 1990, that's when the scanners were modeled. They used an idealized or nominal collimation. They used a standard man, this MERD phantom, which is some people refer to it as a stylized. It's based on geometry or geometric descriptions of organs. There were some that were developed for male and female models. This is the MERD, I think, is a hermaphrodite, which is unusual even for us in California. For the Monte Carlo, there are a number of packages out there that are currently being used. MCMP out of Los Alamos National Lab, that's one that our group uses. EGGS, Geont4, there's a number. In fact, I'm not sure if Jonas is here, but there's a task group on Monte Carlo simulations and benchmarking for all the different groups. Oh, did he just raise his arm? Oh, he's way back there. Okay. There's our task group chair sitting in the back. And what these do is they model the transport of photons from a source. We actually modify the source in MCMP to mimic a CT source. I'll talk some more about the characteristics, but we have it move and it shoots out X-rays and the whole thing. It models probabilistic interactions of photons with tissues, photoelectric Compton Rayleigh scatter. And the tissues need detailed descriptions such as density, composition, and those. And we can get those. There are some descriptions that we can get from things like the NIST website. And these form the basis, as I mentioned, for a lot of computer programs, CT-Dose, Impact, the CT Expo, and for those of you that use the K-factor approach, yes, that is ultimately derived from the Impact Dose calculator work as well. All right, so let's talk briefly about what you need to do to take on this approach. You need to model a couple different things. You need to model the scanner in detail. You need to model the patient. And Peter's going to talk some more about that, so I'm going to go over that lightly. You need to simulate the actual scan, or a representative scan, and you need to tally dose in a organ. So let's talk about that. So to model the scanner, there's a lot of information you need. Some of it is proprietary. We've tried to work on methods to get away from proprietary. work, but you need some understanding of the spectra. Okay? And you need to do this at different beam energies. And obviously the geometry, the focal spot to isocenter, the fan angle, the collimation schemes, things like that. Filtration, the bow tie filter, this is usually where it's typically proprietary, though a couple of us have worked out methods. Adam Turner in the audience published a paper on how to do an equivalent source. But you need this kind of information about filtration. And the tube current modulation scheme, if there's tube current modulation. This is a little trickier. And Erin Angel, who's also in the audience, I'll show you some of her work in just a minute too. Okay, so there you need to model the collimation. And actually, I think I said there, we started with nominal collimations, but realized that was sort of not helping us, so we went to actual collimation. So we actually started measuring, what I mean by that is actual radiation profiles. I shouldn't have said actual collimation, but actual radiation profiles at isocenter. So we incorporated those into our models, such as something like that. Okay, and then modeling the scan. You know where the scan, sometimes you do, but you would like to know the scan path, the path of the source as it goes around the patient. Okay, so you need to know the nominal collimation, the pitch, and preferably the start and stop locations, not of the image data, but you'd really like to know it of the source. So you've even seen articles maybe by us and Di Zhang, I can't see Di, but he's probably out there, where we did something looking at the start angle, okay, of the actual source and where the beam comes on. Okay, if there's tube current modulation, you would like to be able to model that as it goes along the extent of the patient. Okay? All right, and very important, you need to validate your model, right? So you can't just say, I built a model. Well, you can, but you would be stronger if you said, I benchmarked it against some measurements. So you want to benchmark your code against some physical measurements, such as CTDI phantoms or head and body, and simulate a tally in a pencil chamber. Do that at KVPs and different collimations and come up with measurements versus simulated. We aim for less than 5%. I think we've been pretty good at getting less than 5%, and sometimes we've gotten much better than that on some specific models. Okay, briefly, you want to talk about modeling the patient. Again, some groups start with, or some packages have started with the MERD phantom, which is just this stylized, standardized man. These are usually androgynous. They're typically single size. But there have been some work on doing size and age variations of these models. So there are a family of MERD phantoms out there. There's adult male and adult female. And as Peter's going to talk a little bit more about, there's some models for pregnant patients. We'll leave it at that. What you would like to have is the radiosensitive organs identified, the location, the size, and their composition and density. And in that's been done for the MERD phantom, and doing that for other models can be very tricky. I'm going to talk briefly about modeling using voxelized models, which we did based on actual patient scans, and identifying radiosensitive organs, typically manually by torturing some MD or graduate student or resident to say, please outline the following things. I'll show you some examples. It would be good to get we know that age and clearly gender makes a difference here, so it would be good to have a family of models that span age and gender, and Peter's going to talk some more about that as well, and not just age and gender, but different sizes. So there are some models that we've had access to, the GSF models from Maria Zonkel's group, no longer called GSF, it's called Helmholtz Zentrum München, I think. And but they had a baby, a child, 3 adult females, spanning a range of sizes, and they had 3 males, and all with the radiosensitive organs identified by somebody. I don't know who was the saint who did all that, but it's a lot of work. And we've done it so that we've modeled parts of the patient. For example, with some of the work that Erin Angel did, we did the embryo and fetus, and we had a couple folks help us with that, Clint Wellnitz. And then we did breast from thoracic scans of adult females. And I'll show you a couple examples. So here was some CT scan data that was provided to us, and sometimes in a really early gestational age, at 7 weeks, you really can't see very much, but you can see the gestational sac and the uterus, so we had them contour that. And I'll show you what those models look like in a second. Or we had some more mature fetuses, 36 weeks. And these were done for clinically indicated scans. We didn't volunteer anyone to do the pregnant patient scans. These were all clinically indicated scans. But you can see lots of definition. This is going to take a little while to contour, right? But we did, or we had somebody do it. So in the voxelized model, you start with the original image, then you contour, and then you transform that by translating all these tissues into different tissue codes. So we could model the uterus and say all these voxels in red are in uterus, and it has this density and this tissue composition. And then when we go and do a simulation, we transport through the entire body, but we tally in the uterus and gestational sac. For the more mature fetus, we could actually identify and say, that's fetus. No, we did not go beyond that and say, this is fetal brain, this is fetal radius, fetal ulna. That was just a little bit beyond what we had patients for. That's P-A-T-I-E-N-C-E. Okay? All right. For the breast images, we had adult female thorax, and we had someone give us a general outline, and then we used a little bit of image processing to come up with identification of the glandular breast tissue, and then we transformed that into a model. Okay? So we identify lung, we segment breast, and the rest we map to tissue types. We're not so much interested in the dose to muscle per se, so we're not tallying there, but we modeled this as fat or muscle or bone. Okay? Okay, so that's our bit on patient models. You simulate the scan next, the technical parameters. It's almost like sitting at the scanner. Say, what kind of scan would you like? What beam energy, what collimation, what pitch, tube current rotation time, or whether you're using tube current modulation. You select the anatomic region, and you translate that to a start and stop location and a source path. Okay, and then you move your source virtually around the patient and do this transport. So you shoot photons out probabilistic interactions, and then you calculate absorbed dose. It comes out like magic. Okay. A couple of examples of results that we've gotten from this. Again, this is from Aaron Angel's paper in radiology, where we had a graph of patient perimeter. This is the perimeter of the mother, okay, as we measured it on CT, and we tried to standardize how we do that. And on the y-axis, we have the normalized fetal dose. This is milligray per 100 MES. This is for one particular scanner. And I hope this doesn't look like a surprise to you, because on a normalized basis, as the patient size increases, you should see the dose go down. Okay? Okay. So this is the kind of result that we were able to extract from our simulations. Another nice publication that Aaron put together was tube current modulation in female adult chests, and where we were looking at this is the tube current as it goes along the z-axis. We actually have the information about the angular position of the source at the time, and we input this into our Monte Carlo simulation model and tallied dose in the lung and in the breast. So, but we wanted to do a comparison. So the first thing, this curve may look a little familiar or a little similar to the other one. This is for fixed tube current, and this is the breast dose. This is absolute, by the way. So here's patient size. Here's the absolute dose to the breast, okay? And you can see how it decreases with patient size. Now we're going to, we simulated that. That's not how the patient was scanned, but we simulated a constant tube current. But now when we incorporate the detailed information about the tube current simulation, you can see how this relationship changes. Okay? So we knew that it was going to increase the scanner output for the bigger patients. What we weren't sure was whether that increased output was going to result in an increased organ dose compared to what we saw before. And you can see that it does. It's not a dramatic, it's not like factors of 10, but from the smallest to the largest can be a pretty good factor of 2. So we then did a difference and said, here's the benefit, here's the dose savings, and here's the dose increase. And it's kind of what we might have suspected. And I think Phil Judy wrote an editorial a long time ago saying the great thing about tube current modulation is, he's nodding, he said, we get the dose up for the big patients, so we get good image quality. Well, the result is they don't get dose savings compared to that fixed tube current scan, but hopefully the image quality is better. But those smaller patients do benefit. So all that to say, I don't want to focus on this particular result, but say this is the kind of result that we can get from our Monte Carlo simulations. One other thing that I think I'm getting near the end of my part, but is to talk about a couple other set of works that we did, organ dose independent of scanner. We wanted to see the influence of scanner on an individual patient. So imagine taking a patient and now sticking them into a GE scanner, Toshiba, Siemens, Philips. And what difference would it make in terms of dose? Okay, so notice that we anonymized this. We don't know which scanner is which. Don't ask me, I don't remember. But you can see that, and we tried to normalize the playing field as best as we could here. And again, we've gone through the modeling of the source, benchmarking the source, matching it up to CTDI as best we could, and then saying, okay, now, instead of CTDI model, let's put a patient model in there. So we put in the GSF model Irene. She was a more petite female. And we simulated a whole body scan and came up with individual estimates of dose there, okay, for each individual organ that we could on this model. And luckily, that model had all of the organs, not just the breast or the lung. And what you can see is there's a range of close to a factor of 2 difference between scanners if you keep the same. And this the y-axis is organ dose per MAS, okay? Now, that's not the important result. The really important result is it turns out the CTDI behaves almost the same way. So what we did was, on this y-axis now, hold on, let me check. Yeah, it's organ doses normalized by CTDI. Okay, so we pick a KVP, and we normalize by MAS, and we have a collimation, and we do the same thing on the CTDI phantom, and then we divide those two, right? And it turns out that, remember all those differences between the scanners? They're almost gone. So this normalized value, now not all the organs are the same, but the differences between scanners are very, very, very small, within a couple percent. Okay, so that CTDI, it doesn't tell you organ dose, otherwise all these values would be 1. Okay? But it does tell you that the differences between scanners can be explained by the CTDI or accounted for by the CTDI. Okay? So I hope that makes some sense. That was a nice set of work that Adam Turner, sitting right down here, did. Am I plugging my students well enough? You guys doing okay? Okay, good. Okay, another nice set of work and this actually became part of TG204, so that curve should look familiar. We used patient perimeter, and here we did organ dose divided by CTDI for different size models, and you can see the sort of exponential behavior. This was for fixed tube current scans. Okay, and so this actually got incorporated into TG204 as well. Again, comes from Monte Carlo simulation work. Okay, so all I'm trying to do here is lay the platform and talk about, all right, what's the future of dosimetry? Well, clearly we need something about patient size and those size coefficients, for example, from TG204, CTDIvol or its successors, TG111, TG200 methods. And we're going to need some other information too, but we need to at least account for those, and then we might be able to make an estimate of organ dose. And actually, let me point out one other thing that you should notice. See all these? These are all different organs in the abdomen. Okay? And what you see is not much variation between the organs in the abdomen. Now, maybe you're surprised by that, but there is a little bit of difference, but there's not much difference between stomach, liver, adrenals, gallbladder, etc. Okay? Now, maybe abdomen is going to turn out to be just so nice, that's why we started there, because it should be just, close to a hunk of water, and maybe you wouldn't expect much difference between the organ doses, but it is comforting to actually see that. Okay. Again, I submit that organ dose is the building block for things like BEER7 risk estimates, effective dose estimates, but they all use dose to radiosensitive organs. So I submit that's a path that we should be pursuing. I think they're meaningful indicators of dose. I think they're more informative than CTDI, DLP, and effective dose alone. If you do it right, they can take into account differences in the scanner, in patient size, in body region, and if we have enough information, we can use it to take into account information about the tube current modulation. And we think it'll be a better indicator to where we that's left over from another study, or another presentation. We're talking about the sub-millisievert exam. I left it in there, okay. But it'll tell us what the actual dose is and when we hit milestones, like have we gotten below sub-millisieverts. We've demonstrated, I think, that the feasibility of not having to do a detailed analysis on each patient, because we saw these sort of coefficient curves, but let's have some discussion about that as we go through. This isn't quite ready for clinical implementation yet, but we see a pathway there that will take into account all these different parameters. And I think with that, I'll stop, and I'll take 1 or 2 questions while Peter comes up and gets set up. Okay. Phil, if you wouldn't mind, coming to the microphone.
You posed the question of individualized dose, and there's one element I'd like to add to the list that would impact on individualized dose. It's where the patient is in the scan gantry, and given the shaped filters, you can get a considerable variation in the patient dose. And I know at my institution, while you encourage the technologists to center, you can look at it and the patients aren't centered well.
Appreciate that comment. Yes, there are some more details, and that's I'm not sure whether he was advocating that we should center them or not center them. You're saying should, okay. We'll come up with a counterpoint of view on Thursday afternoon. Or maybe it's tomorrow afternoon, isn't it, Dee? Anyway, okay. Anyway. One other question real quick? Or Peter, come on up and we'll get your lecture started up. Let's at least bring your talk up. Go ahead.
Yeah, I was just curious how you determine the spectra, the tube spectra from the different scanners.
Okay, it's a good question. So, in the first stage, we actually had a lot of cooperation. I guess I went through it. I should have acknowledged my collaborators or the technical support we got from GE, Toshiba, Siemens, and Philips on this, where they actually shared with us their spectra. But what we did in the other paper that Adam published last year, 2009, was we basically made half-value layer and quarter-value layer measurements and then went back to things like TASMIP and estimated what the spectra was. And that came out very, very well. It's a really robust estimate. It's a good question. Okay. I'll turn it over to Peter.
May I ask a quick...
Oh.
Sorry.
I missed you.
No, it's okay. I just have a quick question. So in all of your simulations, you're assuming that the CTDIvol is from a helical scan. Have you done any work that looks at CTDIvol contributions that you get in your dose summary or your overall dose from dynamic scan times for contrast exams?
No. You're talking about when we do, for example, if we do a contrast study, we'll do a single scan without the table motion, and then we'll do a test injection, and then several after that, and then we forget what it's called, bolus tracking or...
Right, and I think the different vendors may have different names for that actual scan time. And I've noticed that in our institution, one thing that we're trying to do is minimize that dose, but of course where the dose is deposited in the patient is much different during those scans than it is during a helical scan.
Yes, it is. So we haven't looked at that. We've looked a little bit at neuroperfusion protocols where the table is stationary, but not that specific question. And I think it's an interesting one because, for example, when we do CT angiography of the head, we're going to start our timing scans at the level of the carotid. So we're right over the thyroid, right? And then when we do the scan, it's going to be through the rest of the head. So it's an interesting, because it's a pretty sensitive area. But I don't know the answer to that.